Thank you very much to Dr. Chapman and Dr. Skuyan for the invitation to come and speak to you. I'm going to try, there's a lot of science in this talk, but what I'm going to try and do is tie it back to the clinical perspective to explain to you why this work is clinically relevant and why we're doing this. Before I start my disclosures, I have grants and a consultant agreement with Second Sight, which is a company that works to restore vision, and Medtronics, which manufactures the only marketed deep brain stimulation device. So to put things in perspective, and we're all working in the neurosciences field or clinical neurosciences, but the things that we are treating primarily in neurosurgery, spine disease, brain tumors, are a great source of disability. But if we look at the World Health Organization, and the burden of neurological disease is actually increasing across the world, so within the United States, but also across multiple disease groups. And if you look at it, the areas where there's the most disability, and these are what we call disability-adjusted life years, they're in areas that we're not currently treating with surgical procedures. And the medical therapies aren't so great either, but we see Alzheimer's disease, Parkinson's disease we are treating, but it's relatively small compared to other areas. And then we see migraine or headaches in general, and cerebrovascular disease or stroke. And this is true whether we look now or whether we project into the future in terms of how much disability is, a low-income country, a high-income country. It's just a growing burden. And so there's a desperate need to develop new therapies that can actually address these diseases. One mechanism of doing this is a field of neuromodulation, an idea of trying to modulate the brain or neurons or what have you to try and improve patients' quality of life. But to do it in a patient-specific manner, and I'm going to highlight this point because I think it's one of our shortcomings in our current therapies. And then as we do this, to really improve the efficacy, the efficiency, and the cost of care for these patients. So to give you an idea of the landscape, so neuromodulation right now, this is what we have. We have spinal cord stimulation, which is primarily used for pain in the United States. It's used for other applications outside the United States, which I think we're missing out on, like angina and peripheral vascular disease. Deep brain stimulation is approved for Parkinson's disease, essential tremor, obsessive compulsive disorder, although in a very small number of patients, and intrathecal pumps for pain and spasticity. That's sort of our landscape. That's what we can use. The future, we can use the current technologies, and that's what we've been very good at doing, is trying the technologies that we have for other applications. So spinal cord injury, we have a group that's been working aggressively at UCLA to use spinal cord stimulation to reanimate patients who have paraplegia to help them walk again. Deep brain stimulation for psychiatric diseases, PTSD. We have a trial through our VA center treating PTSD with deep brain stimulation, pain, depression, and then intrathecal pumps for treatment of spinal cord injury to help regenerate the spine, theoretically. What we really want to do, though, is improve these technologies and also expand upon these technologies, meaning add more therapies. So this is sort of the landscape in terms of what's going on in the field of neuromodulation. There are stem cell therapies coming about, gene and hormone therapies, which have come and gone, and I don't know of any major clinical trials ongoing, but focused ultrasound you've probably heard about. Transcranial magnetic stimulation has had a huge boom recently, and that's not a surgical therapy, but psychiatry has really taken off on using non-invasive neurostimulation. And then the idea of using radiosurgery for pain or other functional disorders. So really it's a huge field. But the problem has been that we haven't, despite having all these therapies, haven't made much progress. And what I'm going to try and go over today is really identify what I think are some of the contributing factors to why our field is not moving forward, and why many trials have failed recently, and then come at it from my perspective, which is to use neuroimaging to define the connectivity basis of neuromodulation. And I'll explain what I mean by that in a moment. And then how I use the operating room as my scientific laboratory to really extend this further, using what we know about Parkinson's disease and deep brain stimulation, and hopefully learning something so we can apply it to other diseases in the future. So this is our current state of the art, which is deep brain stimulation therapy. This is what it looks like in the operating room, putting an electrode into someone's brain. There's many different ways of doing this. It's great because it's reversible, it's modulatable, And we've done an outstanding job with treating the diseases that we treat. In Parkinson's disease, there have been many clinical trials now, randomized, blinded clinical trials that show that it works. And to some extent, we've been spoiled by this because we happen to hit a great disease with a great therapy right from the start. And if we hadn't done that, this entire field might be dead. But it turns out that it does work extremely well. In this example, you can see that they randomize people to either deep brain stimulation or best medical therapy. And the darker blue lines here show improvements in many factors in terms of quality of life compared to no improvement with medical therapy. And this is a daily diary. And basically, if you look at the proportion of the day, it doesn't change whether it's in a good condition or a bad condition. After 6 months of the best medical therapy, they don't get better. But with deep brain stimulation, they spend more of their time in a good condition. We really make a difference for these patients. And if you have good patient selection, which is important, patients do fantastically well. Now we flip the coin and we say, well, what's going on with other neuromodulation trials? Despite the success of deep brain stimulation for Parkinson's disease and essential tremor, which has really been around nearly 2 decades now, we've had numerous trials in neuromodulation that just haven't worked. We really haven't moved the field significantly forward in many respects. There's been studies from motor cortex stimulation, for example, for stroke, which the results really showed no success whatsoever. Patients who had motor cortex stimulation, patients who didn't, they looked exactly the same, the 2 cohorts. There was no difference, except for a post hoc analysis which showed some difference based on the level of connectivity that was left in patients' brains, so basically the severity of the stroke. Then there's the very well-known trials, deep brain stimulation for depression. There have been 2 major trials for this, one targeting an area called the ventral capsule, ventral striatum, and area 25. That also failed. And the one thing, if we look at why these trials failed, this is what I'm going to argue, is that part of the problem is that we have a very heterogeneous population. So Parkinson's disease is a pretty, every Parkinson's disease patient is different, but patients with depression, there's lots of different forms of depression, lots of different ways to express depression. Not all strokes are the same because it's an accident of nature, and so not every single person is the same. And so we're not very good at selecting our patients. So we're treating a heterogeneous population with a single type of treatment. We have imprecise targeting. So with Parkinson's disease, we're targeting a very specific area. We can see our target. We can see the subthalamic nucleus. We can see the globus pallidus. But we move to areas like depression where we're targeting this area 25, and I'm going to talk about that a little bit more. It's not a very well-defined target. We can't see it exactly, and people argue about where it is. So if you don't know where it is, but you're putting in electrodes in hundreds of people, if it fails, then you have no idea why you've failed. And then we actually don't know how to stimulate because the best thing that we have to look at is patient's response. And again, I'm going to draw a contrast between Parkinson's disease and depression. With Parkinson's disease or even essential tremor, you turn the stimulator on, you have almost an immediate effect. You know if you're stimulating patients the right way. Whereas depression, you don't turn them on and say, wow, I'm not depressed anymore. It takes months of watching them and seeing what happens. And so you have no biomarker to know that you're doing it the right way. So really what we need better methods to select patients based on these physiologic biomarkers, not just symptoms. So we really need to define our patients a little bit better than what we do currently. Just to drive this point home a little bit more, this is a slide that I often use when I'm just talking about Parkinson's disease or deep brain stimulation from Parkinson's disease. These are the criteria that I list. You have to have a diagnosis of idiopathic Parkinson's disease, cinematic response to this. We can go through this whole list, but when it comes down to it, what does this list mean? We're just doing 2 things. We're just optimizing our patient selection, and we're optimizing our surgical targeting. And so I think what we need to do is take a step back in our field. Instead of just taking a hammer and hitting every nail that we see with our hammer, we need to take a step back and say, how are we going to do this correctly? Should we be putting a deep brain stimulator in every patient or any diagnosis that we can, or should we actually be thinking about this a little bit more? There's a very famous leader in their field of functional neurosurgery who said there's no part of the brain that's safe from a functional neurosurgeon because we can put leads anywhere, but should we be doing that? And I'd argue that probably not. It's important to learn something before we go much forward. And what I propose is that we really need to think of the brain more as a network. And it's not merely a collection of brain areas. So, those of us who studied brain anatomy and functional anatomy, we learn about Broca's area, we learn about Wernicke's area, for example, in language. In Parkinson's disease, we talk about the globus pallidus or the subthalamic nucleus. But now we've really moved to the brain initiative era where we're looking at how the brain connects and coordinates across different areas, this area of the human connectome. And we probably need to do that in neurosurgery and clinical neurosciences as well, and think of the brain as a network, as a dynamic network. And I think that will revolutionize how we approach things. So just to highlight this, often we talk about putting electrodes in the brain for a deep brain for Parkinson's disease or essential tremor. And we put these electrodes in these general areas, but what we talk about often is the subthalamic nucleus or the thalamus, but what we don't see are those white matter tracts that have wires and connections going all over the place, and we are inevitably stimulating all those areas. And we need to have a better understanding of those areas as we move forward and develop new therapies. Highlighting this point, so that area 25 is this white matter area in the front of the brain, in what we call the subgenual cingulate. This is a non-human primate or a monkey study where they did tractography and they did studies to look at the connections of those areas. And you can see within a few millimeters, you move around and you get these vastly different connection patterns. And I'm not going to go into the details here because it's not important. But just to say that, in this one area, which is captured right here, you move up and down just a little bit and you get these very different projection patterns. And you can imagine if you're 1 or 2 millimeters away and you catch these other fibers, you're going to be having different effects, or you're going to fail to achieve what you want to do. So we know there's a lot of connections in the brain. The other thing we know is that when people are diseased, when they have neurological diseases, it doesn't just affect a single brain region. It affects networks, and there's lots of studies. If you look at the basic science neuroimaging journals, it's all about, there's even a journal called Brain Connectivity. It's all about brain connections. This is just one example in minimally conscious state or disorders of consciousness, which is an area that people have looked into for neuromodulation. And what we see is that the brain connections can be different. So patients who are locked in have a different pattern of connectivity from patients with a minimally conscious state, and which are different from vegetative state. And the interesting thing is we have one of my colleagues at UCLA did a study that was published in the New England Journal several years ago, but showing that our assessment of who's in a minimally conscious state or in a vegetative state is not very good at all. We can put patients who we think they're vegetative, which means they have absolutely no interaction with the world, put them in an fMRI scanner, or there's been other studies with EEG, showing that people who we think are vegetative can actually willfully modulate their brain activity. They can answer yes or no questions by showing differences in their brain activity, even though they can't actually communicate with the rest of the world. So it really shows us that we need to be looking a little bit further. The other thing we've learned is that deep brain stimulation, even though for years, until the last couple of years, we've talked about, well, we're stimulating this part of the brain, we're stimulating the subthalamic nucleus, or we're stimulating the globus pallidus. In fact, we're not just stimulating that region, we're stimulating a network. And again, building on the disorders of consciousness work, this is work out of Japan, showing that when the stimulation is on in these patients who seem to wake up with stimulation, you get this widespread change in metabolic activity in the brain when the stimulation works. And when it doesn't work, you don't get that widespread activity. So telling us something about how neuromodulation, it's not just that diseases affect networks, but when where stimulation works, it affects networks as well. And even more recently, we've been able to develop methods to do functional MRI with deep brain stimulation. This is work out of the Mayo Clinic. It's been done in Cleveland Clinic, and we're doing it at UCLA now as well, showing that you can stimulate and cause widespread network activity. Okay. One last point, and this was a very influential paper because it starts to tie in many different fields. As a surgeon, I like to operate on the brain, and my vision is that we put implants in people's brains to make them better. I grant you a little bias in that perspective. Our psychiatrists who aren't surgeons think that's not the solution, that the solution is to do transcranial magnetic stimulation or direct cortical stimulation. But again, getting idea of network modulation, this is a paper by Michael Fox, who's in Boston, showing that you can look at the different areas. So if you look at the deep brain areas that seem to be good areas or targets for addiction, you look at the networks that are associated with that area are the same areas that people are targeting with transcranial magnetic stimulation. And you can look through many different disorders, but basically what you find is that the deep brain targets that we are targeting with surgery are the same targets or connected functionally to the same networks that are targeted with non-invasive stimulation. So these are all related phenomenon. So what I hope I've done at this point is basically make a strong argument that diseases are network-based diseases, and the therapies that we have are network-based therapies. And if we start with that notion, then it completely shifts us away from this idea of targeting a specific part of the brain, and now we're actually targeting networks in the brain, which I think is a critical change in our phenomenology, because instead of saying we're targeting area 25 or we're targeting the ventral capsule, ventral striatum, we're actually targeting either a structural or functional network to try and define the best place to target in a specific patient to achieve our outcomes. So this is my first foray or first demonstration to really show that we can use connectivity-based mapping to target accurately. And a lot of what I've done is build upon what we know in our field of neuromodulation for essential tremor and Parkinson's disease, because we know it works. And if we can show how connectivity supports those therapies, then we can say, all right, we understand how it works in a disease we understand. Now let's move it to other diseases, which is what we'll do with depression in the subsequent part of the talk. So diffusion tractography is this technique that we can use with MRI that looks at the flow of water in individual voxels. So if this room, for example, were a single voxel in MRI, we can tell that the preferential direction of flow of water would be in one direction or another. And if you link up a bunch of voxels in MRI, you can then connect them, and you could say that a certain part of the thalamus, which is demonstrated here, is more connected to the prefrontal cortex. And so we can map out in a heat map here that certain parts of the thalamus are more connected to the prefrontal cortex, certain parts of the thalamus are more connected to the primary motor cortex, and so on and so forth. And suddenly we take this yellow structure, which is the thalamus, and we have a connectivity map. We can see what parts of the thalamus are connected to different parts of the brain, and we can start using that to understand the function and the anatomy of the brain better than we have in the past. This is a brief study that we did just to show that it's actually functionally relevant, but I'm going to move on to the more interesting one, which is to say, you know, the thalamus, we have no internal anatomy. It's just a gray matter nucleus as far as we can tell on an MRI, although anatomically, if you cut it up, there's a lot more detail. But we target it based on looking at the anterior commissure and posterior commissure, which are structural landmarks. And we say, well, we're going to go 6 millimeters in front of the posterior commissure, or 25% of the distance between the AC and PC, to find the perfect place to put our electrode. And it works. It works really well. And that's why we've been so successful. But as we move further and further away from those structural landmarks, the variability increases and we aren't as good at it. But this is a demonstration of ability to do this. And what we did is we said, well, let's see how the thalamus connects to different parts of the brain. And if we look at the part of the thalamus that connects to the premotor cortex, and then we project where our electrodes are in the thalamus, and green are the electrodes, and yellow is the part of the thalamus that's most connected to the premotor cortex. You can see in almost every case, the green or the electrode that works ends up right in that area of the thalamus that is most connected to the premotor cortex. And so suddenly we have a very visual landmark. Instead of measuring indirectly and saying, well, we think it's going to be around here based on things that are around our target, we can actually see exactly where we want to put our electrode. And the one electrode that seems far off here happens to be an electrode that didn't work in a patient. And it's important because the anatomy is different. So you can see those maps that we did in this subject is different from this subject, is different than this subject. And so there's inter-subject variability, so patients are all different. We can't really find a single spot. You can't really normalize this into a single spot without doing these in some kind of patient-specific compensation. So I think This just shows the level of overlap is extremely low, even if you merge all these into a common space. And so this idea that we really need patient-specific therapies, no one will argue in any part of medicine that you don't want patient-specific therapies. What I'm saying here is that we can actually use imaging and connectivity and how the brain is connected to other parts to define that specificity. To sort of drive this point home, this is a connectivity map in one patient who we did a deep brain stimulation for tremor, and this is where we'd expect the electrode to end up. And it turns out when we did it, our electrode was actually a little bit anterior to where we expected. And so I wanted to look into that a little bit more and understand it. And if you map out the sensory cortex, in this case, this was actually where we originally had targeted. We moved it forward because we knew that the thalamus, when we stimulated, it was causing sensory changes. We need to move away from that, and we actually could predict this now with our connectivity mapping. So why does this matter? We know how to target the thalamus. It's interesting because now we move on to ideas of focused ultrasound, which is very intriguing, and I know you do this here, that you can cause a lesion in the thalamus to without having to do deep brain stimulation. And in fact, what we can show is that when you have a good outcome, generally speaking, the lesion directly coincides with that area of connectivity. And generally speaking, poorer outcomes, the lesion is not exactly where that connectivity would predict it to be. And there are also areas of poorer outcome but high concordance, which means that this isn't explaining everything. So I'm not saying I have all the answers, but it gives us some solution. And one of the powers of focused ultrasound is that you get to test it before you do it. But this also opens the opportunity for something like radiosurgery, radiosurgical thalamotomy, which I do think focused ultrasound is going to replace completely. But this idea that if we know exactly where we need to be, then you can proceed with a lot more confidence and do therapies, cause lesions for therapeutic purposes without worrying about causing any permanent damage or permanent negative outcomes. We've done this for other diseases as well. We do some deep brain stimulation for pain, rarely, but we do it. But what we've seen is that when we have a treatment success, we're able to predict where the electrode should be for pain as well. When we miss that target, these are our treatment failures. So again, another good demonstration that we can actually target the areas we know where we want to be. When we miss those areas, we fail in our success. So we've validated in some diseases that we treat. We can also use this tractography to try and understand, there's things that we do. So a commonly held notion when we do deep brain stimulation for Parkinson's disease, at our center we have, there's two targets for Parkinson's disease. There's the globus pallidus and the subthalamic nucleus. Our bias is we stimulate almost everyone at the globus pallidus for various reasons. The one reason we do subthalamic nucleus stimulation is for tremor-dominant disease. Not the major reason. And so this is a group out of, Cameron McIntyre out of Case Western showed that, in fact, you can try and understand why it happens to work better, and it probably has nothing to do with the fact that the subthalamic nucleus is a different target. It happens to do with the subthalamic nucleus is closer to the tracts that go from the cerebellum to the thalamus, and so when you're stimulating the subthalamic nucleus, you're catching another tract that happens to be therapeutically beneficial. So I think this connectivity mapping can give us more insight into why our therapies work, what we're actually trying to target. And we can flip this around as well. In cluster headache, remember I said migraines and headaches are one of the major causes of disability in the United States and the world, and a growing source of disability. There's been several studies that have looked at deep brain stimulation for cluster headache. It turns out, everyone says they're stimulating the posterior hypothalamus, and they just say that vaguely, and then they report their coordinates, but their coordinates are all over the place. Remember I said 2 millimeters in deep brain stimulation is a world apart, and these targets are sometimes more than 3 millimeters apart in multiple directions, so very far apart from one another. And you'd say, well, why are all these different targets working? And so the theory, again, is that maybe what we're doing is activating tracks that are common to these areas. So if you have two areas, they're not the same area, but if you have tracks that you're catching with both of them, then you might be achieving the same outcome. And so what we did is we actually took those different areas and we were able to show through a complex analysis, basically the tracks that are commonly activated across all those regions, including projection areas to the posterior hypothalamus, but not, so the target is not actually in the posterior hypothalamus, but it projects to the hypothalamus, projects to the midbrain, projects to the cerebellum, and those seem to be the common mechanism. So theoretically, anything that can catch those three tracks will actually be beneficial. I'm going to dive a little deeper into depression because that's a big area and that's something we want to understand a little bit better. The major trial, hundreds of millions of dollars invested in this trial that basically stopped. And it was a very big disappointment for many people. And so remember I said there's this area 25, and you can see this bluish area, this reddish area, they don't look that different. So what's the difference between these blues and these reds? These are where the electrodes were in people who had a successful therapy, meaning they had deep brain stimulation, their depression got better, they went into remission. These are people who had deep brain stimulation and did not have successive treatment. And you could say, well, they're exactly in the same place. How are they not effective? Why is this group different than this group? It could be because there's different types of depression. It could also be that the anatomy is different enough in these patients that we're not actually targeting the same thing. And this is some work that Helen Mayberg and Cameron McIntyre have done. But what they showed is they looked at the responders and they looked at non-responders. And they said, well, if we look at our responders and the areas of the brain that their stimulation spreads to, it spreads to the medial prefrontal cortex, the ventral capsule, and it also spreads to the anterior cingulate. If you look at the non-responders, they have the places where their electrodes are, they do not project to those areas. They are not getting the stimulation of those tracks that seem to be critical for a therapeutic effect. So even though anatomically it looks like it's in the right place, you're not actually getting the stimulation to the right place. And they looked at it at 2 years, the same thing. The responders had very robust connectivity to these areas, whereas the non-responders did not have that pattern of connectivity. So now the question is, how do we actually do that? How do we utilize this? If we know or we think that this is important, how do we target that area? And so we've been working on developing methodology that says, okay, here's this large area, this area 25. It's a very large area. You can argue amongst different groups what part of this is the right area. Instead, we said, well, why argue? Why not say, let's just take this entire area and let their brain imaging, let their mapping, let their MRIs tell us where to put it. And what we did is we seeded this area and we said, show us the parts of this area that project to the anterior cingulate. Show us the areas that project to the ventral capsule, ventral striatum. Show us the areas that project to the medial prefrontal cortex and find a hot spot for us in a patient-specific manner. So don't tell us, we don't want to just look at an MRI and say, well, there's the corpus callosum. We think it's going to go right there, which is how the whole study was done. Can you actually show us a hot spot? And I don't want to go through the details of how it's done. But basically, we're able to use connectivity and the structural mapping to define an area that is most connected to all those areas that it needs to be connected to and look at how it relates to our electrode placement. So you can see in this patient, the electrode seems to be right in that hot spot on both sides. In this patient, the electrode is far off. It's several millimeters, if not up to a centimeter away from that hot spot. And this patient actually was a treatment failure. This patient had some improvement overall, ended up remitting. So we're able to see that our anatomic targeting is probably insufficient because it doesn't account for the full array or the full understanding of how those areas are connected to the rest of the brain. So again, I'm going to highlight, we've been spoiled by Parkinson's disease because we have a target we can see. We can see the subthalamic nucleus. We can't see area 25. It's a vague area. And as we look at other diseases, we need to have a better idea of how to target this. So as I said, we have a trial at UCLA at our VA hospital, PTSD. And that's work done by my colleague, Dr. J.P. Langevin, who's done amazing work in animal models and now has moved it to humans and recently published in Biological Psychiatry. The idea is to target the amygdala, which is another part of our limbic system, to try and modify patients' reactions to what really should be non-noxious stimulus, but where they have a post-traumatic response. The amygdala is actually a rather large structure. Sorry, and he showed in animals that he can do this. You can sort of extinguish the post-traumatic response, which is a burying response. So in the animal, you create this fear of this ball, and they're just stressed out by this ball, and so they bury it and shove it away into the corner of their cage, and they're able to extinguish that response with amygdala stimulation. The problem is the amygdala is actually a huge nucleus, and there's no internal architecture, just like we see with the thalamus. And so what we did is we've been looking at the amygdala, which is this big blue region, and looking at how it's connected to the entire rest of the brain, and then letting the data tell us, letting the system drive its own division and identify sub-regions within the amygdala and say, now we have some internal anatomy to the amygdala, and that's helping us target our therapies as we move forward. So we're doing it not just let's get it somewhere in the amygdala, it's let's get it into specific regions of the amygdala and see if there's a better response with one region or the other. Okay, now, this is all non-invasive mapping. What I really like to do as a surgeon is be in the operating room and use the operating room as my laboratory. And why is this important is ultimately what I want to do is use these connectivity methods to be able to make smarter deep brain stimulators. The way we do deep brain stimulation right now is we implant someone, they come to clinic, we turn them on, we see how they do, we adjust it. It's a back and forth. We as the physicians or as the clinicians are the people who close the loop. It's not optimized, it's time consuming, it's not based on physiology. And what we want to do is move to a system where the brain or the deep brain stimulator actually senses what's going on, whether it's at a local specific part of the brain or it's assessing the networks in the brain, and it's able to detect this and program itself in a recurrent fashion so that we can actually implant someone. I'm sure you guys get many patients from out of town, implant them, send them back home, and the system just goes. They don't need to come back. You don't need to do remote programming. You don't need to do anything. It's just an intelligent system. In today's age, we should be able to do that, but we haven't. So I've been talking about doing anatomic methods. Now what we're talking about is using electrophysiological methods, and these are all actually related to one another. Classically, in brain mapping and neurosurgery, we use methods of putting electrodes deep in the brain. We do cortical stimulation, electrocorticography, unit recordings. This is all work that I've done in the past. What I do now is when I do my deep brain stimulation surgeries, where we're putting electrodes deep inside the brain, I take this opportunity. Patients are awake. This is actually one of the major reasons I went into neurosurgery is because it's this opportunity to study the awake, behaving human brain. But we're putting electrodes in the brain. I put an ECOG strip or a strip over the brain. We spend about 20, 25 minutes in the operating room at the end of my surgery to collect data. We have patients do different tasks. We collect signals in the brain. We're trying to understand the anatomy. And again, this is all in Parkinson's disease. And it's not because we really need to understand Parkinson's disease better, although we want to. But if we understand Parkinson's disease and how we can modulate, how deep brain stimulation works in Parkinson's disease, we can then extend it to other diseases as well. But this is our setup. We have a deep brain stimulation electrode. We put a strip under the skull. That gets removed at the end of the surgery. Things that we've discovered that we haven't been able to see before. This is as we advance our electrode to the target of interest. You can see we're getting closer and closer. This is our target region. Without doing any complex math, you can automatically see that this looks very different than this region. And you can see that there's certain biomarkers, electrophysiological signals, that are clearly significantly different within our target region compared to a non-target region. And we're able to describe this very high frequency signal that had previously not been described. We showed that it's actually movement related. So that seems to, we don't know if it's driving movement or if it's related, how it's related to movement, but it's definitely there. It increases with movement, and it seems to be modulated with stimulation. So we know that there's some unique signatures there. Work out of Minnesota at the time had shown that you can actually look at these signals and figure out the best place to stimulate. So that's really important because if we can put our electrodes in, the computer can run its analysis and say, hey, that area has the highest beta band, which is something that we've all been interested in this field. It says you should stimulate there. That's the right place to stimulate. So it's really important to understand this phenomena. Other work, we've done this as well, but this is out of Spain. I just wanted to show many different people's works, showing that when you turn when you give medication, these signals change. So we know that not only can we figure out where to put our electrodes based on these signals, we can actually see that therapy changes these signals. And the therapy can change that high frequency signal that we've seen. It can also change this beta band that we've seen. So now we have not only a biomarker to tell us where to put our electrodes, we have a biomarker that says, hey, whatever therapy you just gave me, it works. And that's actually important because patients who we treat, they're not just getting deep brain stimulation, they're taking drugs, right? They're taking carbidopa, levodopa. And what we do is we stimulate them constantly throughout the day. And you'd think, well, if their drug is working really well, maybe the stimulation should go down. Maybe the stimulation should be dynamic. And this gives us an opportunity to think about being dynamic. Now, I've been talking about connectivity. I just want to briefly not get into details about this. But this idea of connectivity, looking at how two different brain areas actually oscillate together. So the idea is that if two parts of the brain seem to be going up and down in unison, they're somehow functionally connected, they're functionally talking to one another. And then there's this other idea of cross-frequency coupling, which is one area of the brain seems to be driving signals in another part of the brain. We're able to show this between cortex and thalamus, showing that the structural connectivity that we talked about before that I showed you seems to be very strongly correlated with the functional connectivity. So no one's been able to show that before. You can't do it without surgical procedures to show that you can look at the structural connectivity and you actually predict how the areas oscillate together. And you can actually show that one area is modulating another area. And then we went into the deep brain stimulation realm, and now this right here is our cortical signal. Remember I said I put a strip on top of the brain, then we put an electrode deep in the brain. We're able to show that with movement, again, without any mathematical anything, you can see that these areas here look very different than these areas, and that's movement and rest. So we know when someone's moving, whether we're looking at the cortex or we're looking in the globus pallidus. And again, getting this idea, can we actually figure this out? Do we need a sophisticated algorithm? It's not that hard to see it. We're able to predict where these signals are going to be based on baseline characteristics, so we don't need complex algorithms. I'm not going to explain this all in detail, but we can, basically you can see where this gray line and the black line peaks. They generally peak in the same area, so we'll be able to look at just how the brain is in a resting state to figure out where these signals are going to occur. And then most importantly, now getting to the connectivity issue, we're able to see that movement changes the connections between. So the brain basically changes its functional connectivity state. It changes its connections between two brain regions when we move, both with respect to coherence and with respect to this cross-frequency coupling. So movement's important because movement changes signals, and then stimulation also changes signals. So doing recordings while you're stimulating is really complex because you're pumping electricity into the brain and then you're trying to record electrical signals. But we have shown that we can look at the modulation of this beta signal. So when we turn the stimulator on, our beta signal drops, and a sign that our therapy, or it seems to be a biomarker of effective therapy. Again, we're looking for these biomarkers to drive our therapies. This is work out of Phil Starr's group at UCSF, and we've shown the same, that stimulation will actually affect the coupling within the cortex itself. And so in this case, it's a heat map, and I won't get into details of how the heat map is created, but you can see this is before stimulation. When the stimulation's on, that seems to disappear, so that coupling that exists in the cortex disappears, and you turn the stimulation off and it comes back. So another biomarker of therapy that we can use. And the last biomarker I'm going to talk about is this, which is with stimulation, looking at coherence. So looking at how different parts of the brain are oscillating together. And what we find is that when we turn the stimulation on, we disrupt that oscillation. So what we think is happening in Parkinson's disease, and I'm going to say is actually what happens in many diseases, is when you get into a pathological state, the brain gets locked into this strict functional network, meaning everything is working together. You think that sounds good, but actually the brain doesn't want to work together. Every part of the brain should be working independently to actually make us work the way we are. When you get locked into a pathological oscillation, you stop working. And when therapies work, we're actually knocking down that oscillation or that coherence, which is what we see here. With stimulation, we get knocking down of that coherence, and that's what enables people to work again. So we're basically unlocking a locked-in brain in this pathological state. I'm going to skip this next slide. So just to emphasize why we're doing this, why do I care about these signals? And I've given you a brief overview. The idea is, can we understand these signals? Can we find biomarkers to tell us where to stimulate, to tell us when the stimulation is working, tell us when we need to stimulate, and create an intelligence system that can detect these signals, drive itself, so we don't have to program these patients. We can actually be more efficient, let the computer tell us how to stimulate instead of randomly selecting different parameters. It would be better for the patients, it would be better for us as well. And then we can use the same connectivity ideas to really figure out where to put our electrodes in the first place. So, my conclusions from these invasive recordings that they really provide really interesting insight. And we can actually extrapolate this. We are in the process of setting up studies to do deep brain stimulation for pain as well as depression using these same ideas to show when we do effective versus non-effective stimulation that we're actually achieving a therapeutic benefit and it changes the brain physiology in a meaningful way. There's a lot of information there that we don't have access to without neurosurgery. One of the reasons I went into neurosurgery as an undergrad, I was at a conference and George Ogeman, who's from Seattle, was there, and he said, as a neurosurgeon, one of our unique opportunities is to study the human brain that no one else can do the way we can do it. And it's our privilege, and we should be doing that. And that's, as dorky as it sounds, that's really what made me go into neurosurgery. And now here I am doing it. So I'm happy to be doing what I'm doing, but I think it's a really unique opportunity. The take-home point above all else is neuromodulation is a network phenomenon. We've been in this mode of talking about targets, but we're not talking about targets. We're modulating networks, and anatomy is variable. And we have these advanced imaging techniques that the basic scientists have been using for a decade, and we haven't really incorporated into our clinical armamentarium, and I think it's actually going to revolutionize our field. It really will help us develop patient-specific therapies. One last thing I want to state is, we've been working a lot at UCLA. We're very fortunate at UCLA to have many excellent departments. Amongst them, our neurosurgery is outstanding, engineering is outstanding, and we have an outstanding neurosciences program. And so we've really worked hard to build what we call the Center for Neurotechnology, where we all come together, we work together, have different expertise. I've talked a lot about the signal analysis side, but we're working a lot on chip design, device design, understanding the neuroscience behind it, and then clinical translation. So I really think it takes an army. A side story about this, when we first got this group together, we sat in the room. Engineers had never talked to clinicians, and they said, we've got this great idea. We're designing this device. We can do X, Y, and Z. And the clinician, we all looked at them and said, that's great that you can do that. That's totally useless. We have no interest in what you're describing. And we said, this is what we want. And they said, well, if that's what you want, we can do that. That's easy. And it was just like this complete disconnect. And I think that goes on a lot, especially in sort of scientific institutes that do not have a clinical translation. So what we've really tried to do is bring this all together. Finally, just to acknowledge everyone in my lab who's helped me do this work. And thank you very much for this opportunity to talk to you.
I'll start off with something that we see all the time now. We're seeing, as you said, the neuro-related diseases are just really on the increase. And one thing that we see every day in our clinical practice is Parkinson's patients with crooked spines, twisted forward, bent, shaped. Oh yeah, we need Ray-Bans actually for our visiting professor, but no, we have shades. And that is, these patients come to us and they're on all sorts of medications. And again, then I ask them, have you seen a functional neurosurgeon? Because these patients, to me, are pretty far off. And they all tell me, no, you know what, I'm not bad enough. This is not bad enough yet. So how do we respond to this? When should we enact functional neurosurgery, especially in Parkinson's? Because it seems just miraculous what happens. And are we sending patients down the wrong pathway by putting them for a decade or so on a variety of medications, which changes their entire proprioceptive and muscle function dramatically?
Right. So I think that's a very challenging question and multifactorial. So I think the biggest challenge is educating the referring physicians. So referring physicians are primarily neurologists, and most neurologists who are in practice now have either trained in a period before deep brain stimulation or did not have a lot of exposure to it. So a typical neurology resident or trainee does not get exposure to when the right time is for deep brain stimulation. It's really only people who get specialty training. And so I think there's a fundamental gap in knowledge. And so part of our responsibility in neurosurgery is to go out and educate the referring physicians. So that's number one. The other issue is defining when the right time is, and I think that's more of what you were asking. Right now, and I think actually just yesterday, the FDA approved doing deep brain stimulation for earlier disease, for Parkinson's disease. There's a big public announcement about that from Medtronics. But even that early disease for them means disease at least for 4 years and having early motor complications, which is different than the original indications for Parkinson's disease. There's a study that's being organized out of Vanderbilt, a multi-institutional study looking at deep brain stimulation for early, very early disease. And the idea being that deep brain stimulation might be disease modifying, meaning that it could change the disease outcome. I think the other potential is that it may change the exposure to medications or the medication requirements early on, and thereby change the the medication-related complications. I think we don't totally understand when the right time is. Earlier is probably better. But then again, if you go into a neurology clinic, and I work very closely with my neurologist, there are a lot of patients there who've had Parkinson's disease for 10 or 15 years and are managed very effectively with medication and don't need surgery. So I think as surgeons, we see a warped cohort of people who are severely affected, but there are some people who manage quite well. But I think the line is moving forward. We're moving it earlier and earlier to get surgical intervention because it is such an effective therapy.
I'm sure there are many other questions with colleagues way more qualified than me, but let me ask you one more burning question. From what I gather from your phenomenal images is the conventional MRI scans are a very static image, and we obtain it obviously in patients who are near sedated or comatose, hopefully to stay still. Is what you're telling us really an opening towards identifying far more and using far more functional MRI scans in a lot of these disorders?
I think so. That's exactly what I'm saying. So I think the traditional way of doing MRI, which is not just traditional, it's the most common, is very effective when you're trying to understand the anatomy, when you're trying to look at a tumor, when you're trying to identify a specific target, as we have in the past. But I think we need to really move what's been in the basic science domain and move it into mainstream clinical practice, or define how to move it into mainstream clinical practice to understand these functional networks a lot better, functional and structural networks, and help that guide our therapy. There's just a lot more information there. The brain is not a static organ, and I think there's a lot more information there that we can extract from non-invasive imaging to help guide our therapies.
Well, let me see whether there are any questions anywhere. I was curious about Dr. Hanscom being so quiet, and here he is, halfway swallowing down his banana. Is it down? Is it gone? But let me guess. Let me just close my eyes and guess for a second. How can we visualize pain? Is that what you're going to ask? Oh, okay. So let me bring a microphone to Dr. Hanscom. He has a near obsessive fascination with pain. So let's see what's coming.
I'm obsessed with it.
Do you have an overall rehab program you combine this with?
So we do not have a dedicated rehab program. I work with a rehab hospital, Casa Colina Rehabilitation Hospital, which is about 45 minutes from UCLA, that is very interested in this. There are dedicated physical therapy programs, the Loud therapy program and other therapy programs that are specifically targeted at Parkinson's patients to drive exercise. The one thing we tell our patients above all else, above medications, is that exercise and regular exercise is the only thing that's consistently been shown to show a long-term benefit in patients with Parkinson's disease. So we are a very strong believer in exercise, and it should be some level of strenuous exercise. It shouldn't just, if all they can do is walk around the block, then that's fine, but there should be a level of strain to it. And so I'm not surprised to hear that weightlifting has that benefit. There was another study that's been popular on social media lately about, I think it's out of Northwestern, using biking, aggressive biking, and showing some benefits with Parkinson's disease as well. So I think any type of exercise, it's the one thing we tell every single patient every single time we see them. So we are a believer.
So let me ask Dr. Hanscom's second question in the interest of time, because we have one of our neurology colleagues with an important question. My chairman in Dallas, Vert Mooney, who's a well-known spine guy, always told patients, and he did it with this idiosyncratic scratching of his hand when he got a little bit impatient with the low back pain patients. He said, "I can't see your pain. Can you see pain now? Can you visualize pain?"
I can't. There have been a couple studies that have been able to, the handful of studies that have shown that there are certain brain biomarkers that seem to correlate with the severity of pain or with the change in pain scales, and they've helped us localize what parts of the brain seem to be driving pain. The one thing I do know I think I know, is that chronic pain, as insulting as it might sound to some patients, is in the head. It's in people's brains. It's a brain state. It's not that people with chronic pain have, if they have chronic knee pain or chronic back pain, yes, they have something about them that hurts, but it's a disproportionate pain compared to what it should be, right? And what happens is that the brain enters a certain state where they are overly responding to a certain stimulus that shouldn't be painful or is not as painful as they perceive it to be. And so I do think, based on the literature, that you can see those. If you put them in a MRI and you scan them the right way, you can see those phenomena. But I think that the more interesting part for me is if we can figure that out and we know what areas of the brain are involved with that hyper or that exaggerated response to these peripheral stimuli, that we can start targeting those areas and disrupting those networks to try and decrease their attention to that chronic pain.
One of our neurology colleagues, I'll ask her to introduce herself, has a question.
My name's Jenny Witt. I'm one of the movement disorder neurologists here. And I just had a question about Parkinson's. I'm trying to think of the best way to ask this concisely. But even though compared to depression, I totally agree Parkinson's is not as heterogeneous, it is still pretty heterogeneous.
Yes.
And there's a ton of different ways you could parse out so-called subtypes of Parkinson's, and different people have done it, different clusters. But in general, we see that a certain group of symptoms really responds beautifully to DBS, either to GPI or STN. And then we see a really frustrating group of symptoms that don't respond very well, primarily the axial symptoms, so like the camptocormia and spine deformities and neck problems, speech problems, everything in the midline, balance, fascination. And we see a subgroup of people with this more PIGD, postural instability gait type of subtype compared to our tremor dominant people who just respond so well. And I was just wondering what work has been done about looking at a functional connectivity map difference between these different subtypes of patients, and whether that could be useful in defining different targets for these different patients, even within the nucleus that we already use. Like even within STN, are there certain regions that would be better, even though it's a tiny nucleus, or GPI, which is a relatively big nucleus, and if anybody has looked at that.
So there's been some work looking at different subtypes in terms of their functional connectivity and their resting state fMRI. I have to admit, I don't know that right off the top of my head, as well as I know the latter part of your question, which is, are there certain biomarkers to differentiate different subtypes of Parkinson's disease? And I think there are. We've seen over the past year to year and a half, a lot more emphasis, even with these invasive signals that we're recording, of biomarkers specifically related to tremor, biomarkers related to dyskinesia. So when people have dyskinesia, certain signals seem to come out, and then biomarkers that are more related to the rigidity and akinesia. So I think we're starting to parse out those different networks. Now, to just two more points. One is, yes, Parkinson's disease is very heterogeneous, so I knew someone was going to ask me about that. But what we do have is we have a very good we have a physiologic biomarker. It's our Cinemet response that we know they're going to respond. Those symptoms are going to get better. So that's what makes us a little more homogeneous than depression patients. In terms of the other symptoms, my bet is, and I don't know the answer, that they're probably mediated by other circuits. So we're obsessed with this one circuit, the cortical basal ganglia thalamus circuit. But there's probably other circuits that we need to tap into that we may be able to make better. So that's the short answer to your question.
Great question. So we'll have to come to a close. Nadar,
Yes.
this was absolutely outstanding. Congratulations on a phenomenal body of work and making a huge difference.
Thank you. Thank you very much.
In recognition for your work, we have secured the naming rights for one of the preeminent neurosurgeons of not just our times, but through times, Dr. John Jane Sr., with his permission and his family's permission. So we'd like to present you with this plaque for the John Jane Sr. Distinguished Visiting Professorship.
Thank you very much. Appreciate it. Thank you. Wait a minute. The iPhone.